Excellent. Yeah, and thanks so much for the invite. Great to be here. Yeah, like Rachel said, I was down in Brighton at the Earl Data Science Conference yesterday. I was talking about something quite different to this, talking about how we do storytelling with data at the British Red Cross, and thinking of this maybe now as me being on tour, much like Taylor Swift. Today, I'm in the health equity era of our career. So I'm going to talk about the way that we're thinking about health equity, health inequalities at the British Red Cross, and how we're using data science to support our health and care teams do the fabulous work that they do. Just a word of warning for any health equity experts on the call. I'm going to use equity and equality very interchangeably, so apologies for that, but it's broadly in that sphere that we're going to be focusing on. But I just want to kick off by talking about what the British Red Cross does in the realm of health and care. We're probably more famous for our work in disaster response, particularly internationally, though we do a lot of that in the UK as well. And we're also the UK's largest independent provider of support to refugees and people seeking asylum. But today I want to focus on this middle bit, number 2 here, which is our work around health inequalities. And this is fundamentally about supporting people who might be falling through gaps in the health and care system across the whole of the UK. We work in all 4 nations of the UK, and the kinds of support we provide, I've listed here. We do assisted discharge services, discharge to assess, particularly on Pathway Zero, support at home services, so a mix of sort of short to medium term support to help people get set up and live independently at their homes after a stay in hospital. We're starting to work on virtual wards, or in devolved nations, what they call hospital at home. And our focus there is particularly around equity of access. So people who might not otherwise be able to access a virtual ward for whatever reason, including digital exclusion, we're trying to focus on the equity piece there. We do some regulated services, including some short-term care at home. One of the big things that we do and growing is high-intensity use programs. So for people who are frequently attending A&E, but don't necessarily have clinical reasons to present to A&E, and we provide wraparound, quite holistic health coaching for people in those situations. And we also do a lot of non-emergency patient transport, so things like bariatrics transport. And this is very much in the sphere of commissioned services that we offer. We have services commissioned by the NHS as well as by local authorities and others. And this kind of support is very much around giving flexible, bespoke, person-centered support across our entire suite of services. And the impact that we try to have on the health and care system is very much around freeing up clinician time and improving patient flow at all points of the health and care system. But we're increasingly moving into more of a health equity space as well. And we've been doing some pilot work with more community-based health equity services, and certainly working in partnership with other voluntary sector providers to deliver much more targeted neighbourhood level support. And some of the tools and analyses I'm going to talk about today helps us both target our commission services, but also helps us think through developing these much more localised health equity services. And this quote is from my colleague Caroline Holt, who is Director of Disasters, Climate and Crisis at the International Federation of Red Cross and Red Crescent Societies. I love this quote. I think it really sums up why data, why analysis and data science is fundamental to doing humanitarian work in the 21st century. She describes it as becoming the new frontier of humanitarian work. And we certainly see that with all of the work that we do in the UK. It's how we are engaging with people who are in vulnerable situations. It's how we understand humanitarian needs. It's how we understand the scale of humanitarian needs across the UK and how they might be evolving in future, how new needs might be developing over time. And increasingly in the work that we do, talking to governments, talking to policymakers, talking to decision makers, including at the NHS, at a national level and locally, using data is just more and more a way that we're trying to communicate the needs that we're seeing and offer solutions in partnership with various bodies. So I want to talk about mostly talk about a tool that we've been building, the Health Inequalities Explorer, but then use that to Trojan horse in this thing that we're calling the humaniverse, which is more our underlying data science infrastructure that we've been building to help with this and other projects. The way that we've been thinking about mapping health inequalities across the UK is based around these three categories. For us, it's about places with the poorest health and highest risks of people developing poor health. And it's also about who is living in these places in terms of demographic groups, but also people who are typically socially excluded, the so-called health inclusion groups. And both of those might be really familiar to you if you've done work around the core 20+5. We're very much in that core 20 plus space, but also because we do so much in the way of commissioned work and we want to understand how health system pressures, health and care system pressures might be influencing health and help us understand where we might need to step in and offer support. We've also put a lot of effort into trying to map local health and care system performance across the whole of the UK. So this is the broad ambition for our Health Inequalities Explorer tool. And I've got a nice little animated GIF here. I was thinking about doing a live demo, but I don't hate myself. So you've got an animated GIF instead that hopefully will animate, but my PowerPoint's been playing up, so it might just stay like this. But I'll talk you through some of it in a bit. But broadly, this is a publicly accessible web app that we've been putting together. There's a link and a QR code on this slide if you want to go and have a play yourselves. Just a word of warning, it's not designed for mobile use, so definitely better to open this on a desktop. And this is a nice scrolly interactive website that we've put together to help people explore various health and care related data sets that we've built across all 4 nations of the UK. And you can use it if you want to explore a particular region, or if you want to explore, say, a health board versus a local authority. You can see different kinds of geography. I noticed on the Menti at the beginning, there's a head of colouring in on the call. Hopefully we've got some lovely maps for you during this call. So yeah, since this is clearly not animating, I'll just move on and talk a bit more in detail about what we've got in the content of the Health Inequalities Explorer. So the way that we've been designing this is very heavily influenced by how the Office for National Statistics have been mapping and sharing local statistics. I thought their interface was really, really neat. So inspired by that, the bulk of the visualizations in our Health Inequalities Explorer are these jitter plots, where you can see at a glance a spread of either local authorities, or in England, we've got integrated care board data. You can see how areas are spread on various variables. So here, these are some of our more population health measures. We've got a risk index of loneliness that we've built for the UK, which is based on some work done a few years ago by the ONS Data Science Campus. We've got some stats much more related to the core 20, like deprivation and left behind areas. So these are areas that also lack social infrastructure, as well as being highly deprived. And we've got an index that we've been building that I'll talk more about a little bit later, that's modeling access to healthcare in terms of physical access, like can you get there either by driving or by public transport, but also digital access, so digital exclusion, essentially. And the app lets you choose areas that you want to zoom in on. So here I've selected Birmingham, Solihull and Black Country. You can see at a glance, here are the areas selected and where they stand in relation to other areas. And the way that we've been thinking about these kinds of charts is we wanted to have some consistency across the whole of the app. It's quite a long scrolling app, and you've got different sections for population health data, secondary care data, health and care system data, and demographics. And to keep a consistency, so once you figured out how to read one bit of the graph, you know how to read everything else. We've made sure that in everything, worse performance, greater vulnerability, higher risk, and so on, is always towards the left of the charts, with a dotted line bang down the middle showing the average, so you can just see where things are not performing as they should, and also in relation to one another. And like I said, these jitter plots show variation and show your highlighted areas. We've got tooltips that pop up when you hover over stuff, giving much more detail about each of the indicators. And we've also normalized all of the indicators across the whole of the app so that we can allow easy comparison across the areas. We're also doing a lot of hand holding for users as well. We've got lots of supporting explanations that users can either show or hide depending on whether they know what's being shown or not. So this just does a little accordion that opens up and gives more detail on what the graphs are showing. There's also little help buttons against each of the graphs that tells you how to read the graph. And because they're interactive graphs, you can also do things like zoom in, or you can download as an image what's in the chart. And it just talks you through how to do all of that. So, for example, for our teams who are developing bids for commissioners, they want to include charts in there. And so it just gives them a really easy route to doing some analyses and displaying that for health and care commissioners. And I'm going to talk more about this health index a bit later, but this is one of the ways that we're trying to delve a bit deeper into health inequalities within places. And we have split out this overall index of health for the nation into its constituent parts, so that users can see at a glance health outcomes in an area and how they're performing, for example, against the average for England, as well as how they're performing against each other. We've got wider determinants of health in there as well, and you can again see comparisons across areas and comparisons to the average, and preventable risk factors, modifiable behaviours, that kind of stuff as the third domain. And then the app lets you drill down even further into what makes up those big three overall domains. So, for example, for health outcomes, that's split into things like ADLs and mental health and different kinds of mortality, including preventable mortality. And this shows you on a table how each area is performing. We've also highlighted which areas are performing the worst, as in like far below average compared to other areas. We found doing some testing with some of our health and care teams that this isn't as intuitive as we would like. So we're in the process of rethinking how we're going to present this kind of information. But essentially, we want it to be really clear at a glance how an area is performing and what they're performing particularly poorly on, so that if you are doing localized kinds of design for support, then this will really enable you to zoom in on the key issues in a place. And later in the talk, I'll give a bit more technical detail about how we've been building the Health Inequalities Explorer, and also talk a bit about how we've been thinking about the design of it. But to begin with, I just want to talk a bit about our humaniverse. This is a suite of packages in the R programming language. We're primarily an R house. My team at the Red Cross, we do dabble in some Python as well, but most of what we build is in R. And because we found that we're using the same kinds of data and doing similar kinds of data wrangling and similar kinds of data analyses with different data sets, we've, over the last 3-4 years, built this entire suite, this humaniverse of packages to help us do the work that we do. There's a QR code on here and a link on here. It's all open source. Do go and have a play. And we've been thinking about the way that we build this is based around 4 kind of key principles. One is doing it open source. I love open source. I think it's the best way to design software and do data analysis and share data and things like that. And because we're entirely using publicly available data sets, we are able to publish our data open source as well, including some of the data products that we produce, which I'll talk about shortly. But open source also allows us to collaborate with others as well. We do a lot of work with academic institutions, research groups, for example. We have volunteers who work with us, we have interns who work with us, and doing this open allows us to do this really well and allows us to do version control and all that other good stuff. And speaking of version control, we're very into quality assurance, and we want to make sure that our analyses are reproducible and repeatable. Particularly, I think this is important for us in 2 key areas. One of them is where decisions are being made about constrained, restricted, limited charitable resources. So, for example, donations and spending charity money, but also how we allocate the time of our volunteers and our staff, and making sure that the work that we're doing to support people in vulnerable situations is having the greatest impact at the greatest scale it can. And so we need to make sure that the information that's informing some of these decisions about allocation are really high quality and that we can do reproducible, repeatable analyses. But also because our teams across the Red Cross do a lot of engagement with government and NHS and policymakers and decision makers, where we are doing a lot more external facing work, we want to make sure that that's really high quality as well. So having this infrastructure is our way of making that much more straightforward in the design. And it also helps us do things quickly as well. Fundamentally, the Red Cross is an emergency response organisation, and we do a lot of rapid analyses. And because we've got all of this data infrastructure, all the data, all the tooling that we need to do these kinds of work around understanding humanitarian needs, targeting services, this allows us to do things really rapidly. And at heart, this is us being kind to our future selves. There's an adage in software engineering that your most important collaborator is yourself in 6 months' time. And you're probably going to forget stuff, not know where code is, or find that you just have to bring in the same kind of data set in the same kind of way, do some wrangling you've already done before, and you can't remember where the old code is, or it's not commented well. And so having this in a more formalized set of packages allows us to do this kind of work really well. And being kind to your future self means it's easier to be kind to other collaborators as well, who might be coming in fresh, and having more of a structured way of providing data and tools really enables collaborations to flourish well. And this is a little overview of the humaniverse. There's quite a few packages in there now. We've also developed these lovely little hex logos for most of them as well, because they just look really cool. The ones that I want to focus on that relate to our work around health and health inequality are these highlighted ones. And all of these are packages that have been fundamental to building the Health Inequalities Explorer. And it's a mix of packages providing data, which are most of these highlighted ones. So we've got a package that gives us access to different kinds of demographic information, for example, access to various kinds of health and care information. And I'll do a bit more of a dive into this Health ER package shortly. We've got a package focused just on geography in the UK. It's difficult to get, even with the ONS's brilliant geoportal. It can be quite hard to get geographical data into your data analysis software. So this makes it much easier for us, and also helps us wrangle different kinds of geographies together. So if you've got, say, local authority level data and neighborhood level data, you can easily aggregate up or down with the functions we've got in there. And we've got a few packages that I'll talk a bit more about as we get into the details of the Health Inequalities Explorer. But broadly, these maps related to risk, so things like loneliness, things like deprivation and social infrastructure, and also access to the health and care system. And then finally, we've got this package Compositor, which is something that we're more actively building out at the moment as the way that we want to use to build the kinds of maps that we need to use, because humanitarians love maps, and we use a lot of composite indices in our work, and we build a lot of composite indices as well. And having a package like Compositor gives us kind of a set of recipes for building composite indices. It's not finished yet, but it will be something that we work on and release to others who want to do this kind of work as well. And our work on composite indices really went back to the COVID-19 pandemic. We developed a COVID-19 vulnerability index, which took a very broad and holistic approach to understanding vulnerability, including social and economic factors, social and economic vulnerabilities. And it just was so useful for the work that we do at the Red Cross that we've ended up making lots of other domain-specific indices as well. So, for example, this one in the middle is our digital mental and physical access to healthcare index DEPARI. And this takes various open source data sets and merges them together to help us understand where people might be experiencing difficulties getting to health and care system appointments. But we don't just build, we also use other good stuff as well. So for example, the IMD package is using the Index for Multiple Deprivation, one for each of the 4 UK nations, as well as the Community Needs Index for social infrastructure. And we've also got in there the Health Index, which I think is a really brilliant piece of work that I want to just spend a bit of time talking about. The idea came out of the Health 2040 report, which was when Dame Sally Davis was CMO, and it was one of the things recommended as a way of eventually becoming an official measure of health in the nation. I think recently the ONS have decided to pause work on this, which is very sad because I think it's absolutely brilliant. But it offers a very good, very comprehensive definition of health based around things like health outcomes and health status. So difficulties in daily life, mental health, personal well-being, physical, mental health conditions, but also modifiable risks, lifestyle, behavior, preventable risks, that kind of stuff, and wider determinants of health, social determinants of health based on access to green spaces, access to various kinds of services, including healthcare services, crime levels in a local area, working conditions, economic conditions, living conditions, environmental impacts. So we love this, particularly for the kinds of targeted health equity work that we're looking to develop. And a really nice thing about this is that it's a spatial as well as a temporal index. So you get local authority level data that tracks health over time, and that's superbly helpful. But we've noticed a data gap in that this is only for England. And so we've been investing time and will continue to invest time over the next year or so in building versions for the devolved nations as well. They're not going to be longitudinal. We don't have the capacity to do that, but it will be a point in time way of measuring similar health across the whole of the UK. And I want to just talk, this is one of 2 more technical slides that I've got in this talk. So I wanted to give a bit more of a sense about how we structure the packages in the humaniverse, particularly for those of you who are perhaps package makers or package users working in R, and talk a bit about some of the data sets we've got in here for those of you who like using data sets. So this is, the way that we've structured this is, these are fundamentally packages that provide data to people. So each of them have got a data folder that contains the wrangled, cleaned, tidy data sets that can be shared externally. Behind the scenes, which you can get on the GitHub repos for each of these packages, are the files that we've put together that do all of the data cleaning and the data wrangling. So you can see exactly all the steps that we've taken in order to go from a file that we've downloaded, for example, from NHS England's website, to how we've wrangled it, how we're saving it, what format it's in, and also documenting everything as well. So you can read a short summary of what the data set is and what's in the data set. And some of our packages also contain extra functions as well. For example, some contain functions for aggregating data between different geographical levels. I don't think any of that's in Health ER. I think it's purely a data package. And the links at the bottom take you both to the GitHub repo for the Health ER package itself, but we've also recently started hosting our packages on this website called Our Universe, which looks absolutely brilliant. It's kind of a package repository that has a very low barrier to entry. So it's really easy to get your packages uploaded and shared on Our Universe. And a really neat feature that they've introduced recently is exporting data sets automatically. So if you've got an R package that contains a data file that you can then, so if you load it into R, you can access this data set. Our Universe automatically takes that data set and converts it into a variety of formats, including CSV files and JSON files, and they host it for you on their website. And so you've got a direct link through their API to get access to this data. So you don't even have to load the R package, or you could share your data with people who don't use R, and they can just get directly access to the spreadsheet version of the data. I think that's super neat and something that we're looking at taking more advantage of in the future. And just to give an overview of the kinds of data we've got in Health ER, and this is all publicly available data. So in this case, I've focused on the stuff we've got for England. We've got trust level data and ICB level data on A&E attendance and admissions, on criteria to reside, on bed occupancy, on discharges, on IAPT. So we've got some good like mental health referral data, waiting time data, and also referral to treatment waiting times. So trying to get a reasonably comprehensive set of the main signals of patient flow across the health and care system. And we need to do more work on this as well. That you'll notice things like social care are missing, and because we do regulated social care services, we want to have some of those data sets in the mix as well. And currently, this is the place where we host some of the data sets around health inclusion groups, socially excluded groups as well. So thinking about, we've built this based on how OHID think about health inclusion and socially excluded groups. So, for example, people who have who've been in contact with the justice system. For now, we're using a crime severity score, which is an experimental statistic published by the Office for National Statistics. And we've got data in there on disability, on statutory homelessness, on sexual orientation from the census, but also we've got other data in our demographer package as well. So you can go, it's all publicly available, so you can go and have a play and see what you think of all of those data sets in there at various kinds of geographic levels. So that's the infrastructure that we've been building to help us do things like build these public facing web apps. And I just want to spend a bit of time talking about how we've been thinking about the design of these kinds of apps. And you might have come across this dichotomy between explaining and exploring in terms of what analyses are for, what analyses are trying to do. And I found it is often presented as a dichotomy, but I think of it more as a spectrum. And the kinds of work that we do fit all the way along the spectrum from explaining to exploring. That depends on what it is you're trying to achieve and what your audience is, what your users are trying to achieve. So an example of the kinds of work that my team produces that's firmly at the explaining end of the spectrum are things like ICB profiles that we put together last year. So working with our health and care teams, we identified a few ICBs and equivalent health boards in devolved nations that they particularly wanted to focus on in terms of developing more commission services. And so we did some qualitative analyses in here, looking at things like what's in the ICB plans and strategies, what are the ICB priorities, but then also taking more of a population health and health equity lens on things, where we did some mapping about deprivation or access to healthcare, who's at risk of developing various kinds of health conditions, what are the demographics like in areas. And these were very much static slide decks, so not a thing you can interact with, not a thing you can really explore. It was designed to tell you a story. But then much more towards the exploring end are things like the Health Inequalities Explorer, which I think of as tools that we're designing and developing in order to help others tell stories. So like our teams that are developing healthcare services within communities, they're trying to tell a story about needs in a place and how services like the Red Cross provide could support with that. And so what we're doing as a team that produces these tools is giving them the tools they need in order to tell those stories. And we've taken very much a product design approach to building this app, and we take a product approach to a lot of our work increasingly. Don't worry about the details on this. This is just a screenshot from a Miro board that has been evolving over the last couple of years as we've been designing and iterating on the Health Inequalities Explorer. This is more to show just some of the ways that we've been thinking about design. So at the very top here, this is where we set out the initial needs analysis and the initial pitch for the tool, and then spent some time thinking about features that might be needed and discussing that with healthcare teams, and also data sets that would go into the tool. It's also a place where we've actively been doing and analysing user research, turning them into things like user stories and jobs to be done. So really pithy summaries of what teams are trying to achieve, what users are trying to achieve, and then what they need from a tool like the Health Inequalities Explorer in order to do so. Because this has become very popular among our teams, we've also done things like prioritizing the development of different features and the ingestion of different data sets based on things like how impactful it would be to their work were they to have a particular feature, but also how much effort it takes as a data science team to develop these kinds of features. And then we can think very clearly about the trade-offs between effort and impact. And increasingly, I've been thinking about this as being firmly about products all the way down. So obviously, an app like the Health Inequalities Explorer is a product. I'd argue, and I think others would agree in the kind of R development ecosystem, that R packages are products. They have clear users, other people who use the R language, and should be designed as products so that they're easy to use. They meet people's needs. They make sense, for example. So when you're developing say an API, or if you're developing a function, you want to have your user, your intended audience in mind in order to do so. But I also think of the underlying data that we're producing, particularly as products as well. So the composite indices that we're building, like the Health Index for Devolved Nations, or a Loneliness Index, or this DPARI Index for digital and physical access to healthcare, these are firmly products as well. Mostly products that would be used by us in our R packages, but because we make everything openly accessible, we don't really have control over who else could use them. So we want to make sure that they're presented in a way that is thinking about potential users and what they might need from these data products and the R packages that wrap around them. And so we try to think like designers. I'm not going to go into detail of this rather complicated diagram, but it comes from the Design Council, and it's well worth reading about their design frameworks. I think they've done like such a wonderful job over the last quite a long time now in developing these product design and service design approaches. But I do want to briefly zoom in on this double diamond in the middle that may be more familiar to you. And essentially, this part of the product design approach is about building a shared understanding of problems and co-designing solutions with your users, with your audiences. And they're split into two diamonds. One is around the problem spaces, understanding what's going on and starting to come up with hypotheses. Is this what's going on, or is it this? And then really defining what is the thing you're trying to tackle with the product you're building, whether that product is a web app or an R package, or even an analysis, a data story that you're trying to tell. And then once you're clear and have a shared understanding of problems, moving into this space of solutions where you're thinking about what could we do about this? How do we solve this problem? And what should we do about it? Allows you to start doing very directed prototypes, solution building. And I like to think of prototypes in two ways. They should be things that fail quickly, so you know they're not going to work, but also things that fail well. And what I mean by that is you learn from the failures and you can go back into the problem space knowing more than you knew before. You know what doesn't work and maybe have some inclinations about what else might work. And you can go back and rethink about the problems and come up with more hypotheses about, like, is this what's going on instead? And then go back into the solution space. And it just kind of naturally pushes you much more towards impactful answers. And I really like this way of thinking about product design. And thinking about sort of principles that we try to abide by, it's really about understanding our audiences, knowing their needs, not just what people say they want, but really trying to understand what it is they need in order to make the decisions they need to make or take the actions that they need to take. And particularly where there's a lot of deep expertise among our service delivery teams, for example, and that means there's a lot of tacit knowledge, and it can be really hard to turn tacit knowledge into something you articulate, a need that you articulate. And so we're trying to work on our approach to doing user research so we can be much more helpful in facilitating teams to articulate their needs, which then in turn helps us design better products for them. And as I showed in that products all the way down slide, we're treating more and more of what we do like a product. And this is something particularly for the data scientists among you. I'd suggest thinking about treating almost everything you make as if it's a product. And be kind to your future selves. The work that we do, we have to repeat a lot of things. We have to work really quickly. And so having this data science infrastructure like the humaniverse really helps us do this well. And I promised a second techie slide. This is the next techie slide for those of you who are very much in the R development world or who are interested in app development. I just want to show how we've been structuring the Health Inequalities Explorer. So it's an app we've developed in R Shiny, and the code has been structured as an R package. There's a great book called Mastering Shiny that advocates if you've got an app of any kind of complexity or large size, structuring it as an R package really helps simplify your workflow and allows your package to talk to other packages quite easily. So we've got it publicly available as an R package that runs as an app, and then it's linked intrinsically to our humaniverse. We've got, for example, the Healthy R package, which has got all this lovely data from the 4 NHSs across the UK and loads more besides. And then behind the scenes, we've got a bunch of R scripts that do all the data pre-processing and storing the files in the Health Inequalities Explorer R package so that they're really easy to access. And it means every time that you're loading the app, you don't have to wait for lots of processing to be done. We've pre-processed it, so really the app is about visualization rather than calculation. For the user interface of it, I think we've got a really, really nice user interface. It's clean, it's really easy to explore. We've been using the grid layout package for that. It is a package that's still in development, so you could argue we shouldn't be using it for a productionized app, but it is a very neat way of making something look very pretty, and pretty things are things that are more likely to be used by various people. And then behind the scenes, we've been building this Shiny app in a modular way, using Shiny modules for various user interface components. This here shows the different subcomponents that we're using for the jitter plots that I showed earlier. So each jitter plot has got a user interface and a server function, and then we've got 4 supporting functions that show different plots in different stages. So helping us with the data preparation, helping us show something on a plot if the user hasn't selected anything compared to if they do select a particular area, and also abstracting out some functions that we use over and over again in different kinds of charts, for example. So this ggplotly default function just saves us having to write the same chart drawing code over and over again. And then wrapping all of that together, we publish it on shinyapps.io. We've got a paid instance on there. It's I think it's the basic tier or whatever one of the cheaper ones is, but still gives you a generous amount of computing power and memory on there. So you can host reasonably complicated apps on there, and it means they are very easily publicly available, and it's very easy to deploy new things. And we're thinking about the future of this app, and we want to speed it up. You'll find if you do use it, it can be a little bit slow. So we've been thinking about ways that we might do the data ingestion smarter. So our universe is one thing that we're looking at, where you can just get API access to lots of data sets really easily. Or at the data science conference I was at yesterday, there was somebody talking about this thing DuckDB, and it sounds bonkersly fast. Like, it can hold large amounts of data and you can read them super, super quickly. So I'm going to go and nerd out on that a little bit later. It sounds great. And I just want to finish by talking a bit about what we're building next. So I mentioned building health indexes for the devolved nations. We're working on that over the next year. One thing that I'd be interested in case any of you have built composite indices before, is what you would do if you have more indicators than data points. So, for example, in Northern Ireland, there's only 11 local authorities, but the health index has got, I think, nearly 100 indicators in there. So what do you do when you need to try and turn a data set that's got 11 rows and I know, let's say 90 columns into one composite index. The normal methods that we would use, like doing a PCA, don't work in this kind of instance. So if anyone's struggled with and solved that problem before, I'd love to hear more from you. We're also going to invest some time in improving the Health Inequality Explorer app's user experience. We want to speed it up using some of these options that I mentioned just now. But one thing as well I want to think about is how to make it easier as a tool to help others tell stories. So we've just got lots of charts on there and we kind of leave it up to the user to figure out what's going on. Could we do an extra bit of hand holding in there, for example, by generating more narrative insights? So somebody looking at it could read a paragraph that just tells the story about the local area they've selected based on what all the indicators are looking like. And an unrelated, but I think really, really cool thing that we're also looking at is having an AI-fueled analysis of social determinants of health. So our commissioned health services, our teams delivering those services take referral notes for people who get referred to us by, for example, a hospital. And we've got years and years worth of these referral notes. And we know that there's signal in there. For example, we know that people write down, for example, if somebody's got a physical or a mental health condition in there, and we can extract that from these data sets. But one thing that we want to look at is using various natural language processing approaches to see whether we can identify signals of social determinants of health in there as well. So that's something we're going to work on over the next couple of months. And again, if any of you have solved this already or are interested in just having a chat about it, we'd love to do so. And all of these are projects that we're doing with the Institute for Health Equity at UCL. So it's a really interesting and exciting partnership that we're developing with them. And yeah, I look forward to sharing more about that soon. But yeah, that's it for what I wanted to talk about today. I'm very happy to take any questions.
Thank you, Matt. That was wonderful. Such an in-depth. I mean, one of the questions. So I'm going to share my screen. One of the questions was, in fact, how long did this take to for you to develop thus far? So if there's a lot of work gone into this, clearly. Let's just say I'm sure that was one of the questions. Yeah, so it does indeed look amazing. So how long did it take, Matt? A couple of weeks, I imagine.
So we've been developing the Health Inequalities Explorer for a little over 2 years now.
Okay.
I think I think it might have been in August. It had its 2-year birthday of being published for the first time. So actually, yeah, we've been developing it for about 2.5 years now.
Yeah.
It's been publicly accessible for about 2 years. The underlying infrastructure, the humaniverse, we've been developing that, I think, pretty much since early days in the pandemic. That's where we were building our COVID-19 vulnerability index and then just starting to notice we're using the same kinds of data sets and the same kinds of functions over and over. So our data scientist at the time, Mike Page, started wrapping some of these up into R packages. And then since then, Jenna Tan, our current senior data scientist, and I and some of our interns and other collaborators, we have been taking that and just further rounding it out and adding more data sets, more packages.
And it continues to develop as you're talking about. I do like the third point of what you're doing next, the natural language and sort of AI approach to some of those notes. I think I know a lot of people are starting to look at that, but I think that'll be really valuable, especially as you say you've got data going back years and years. So that's going to be really interesting to pick out those social determinants as well, because that's where the real sort of real information in terms of prevention and sort of understanding who's out there lies, isn't it? So you've got a couple more points here. What have we got? People, being kind to your future self. We love that, of course we do. That you should think about that, and of course if you're being kind to yourself, you're actually being kind to other people as well, because you're designing things right. You're thinking about the future and other people who are going to be using your work. So there's just a couple of other points here. So how frequently does the data update? So this is just being, obviously it depends on the source, but being sure that no matter what the source is, it is in fact sort of maintained routinely. And I suppose there is that thing when people start to fall in love with a particular app or resource, they want to be assured that this is a long-standing relationship, and they can sort of, this can be a reliable source of information and for them.
Yeah, absolutely. Yeah, and that's a really good point as well. And I think a fundamental aspect to product development as well, you are by inherently taking a product design approach, you're signaling that you're building something that is going to be maintained, and you can enter into that like long-term relationship, as it were. So for us, it depends on the package, because we've got lots and lots of different packages. For the healthcare ones, our ambition is to update the health and care system indicators once a quarter. We want them to be up to date for our healthcare teams using it. But because we have loads of packages in here, including on things like asylum statistics, which are also published quarterly, and things that are published much less frequently, I think we need to have a stronger think about how we dedicate time to that updating. But certainly our ambition is to make sure everything updates at least on a quarterly basis. But there's stuff in there that, I know, like say the index for multiple deprivation, that updates roughly every 5 years, and so we'll update that as and when. But yeah, for the regular stuff, we want to make sure it's reasonably up to date.
No, that's useful and good to hear. I was going to say something else, but I completely forgotten what I was going to say. I was thinking about the quote that you put up, which I really liked, by the way. I thought that was a really, really sort of excellent quote, and it's just sort of reinforces the idea of the value of data, and just being able to sort of combine all these data sets because there is so much out there, and the trick is to be able to do it in an efficient way. And I like the design of the approach as well. You did a flash up of the thinking that went into how you came to the different elements, and considering all the different data sets and so on. And then of course the user, what does the user need in all of this as well. So that goes on for me to think about what are you able to say what the impact of this has been so far? How's it gone down? How useful has it been? Have you actually changed the way that things are done, and the impact it's having on patients or sort of people's lives? Are you able to show any of that?
Yeah, so it's hard to do that sort of further down the line evaluation, impact on people we're supporting, because there's just so much that happens in the middle that it's really like, to use a phrase from the world of evaluation and theory of change, it's beyond our accountability threshold. But the stuff that so one thing that I've really loved is, at the moment, we're in our annual planning phase at the Red Cross, and it's been really nice seeing some of the plans from our local healthcare teams, where they've got these slide decks they're putting together, setting out their plans and the needs that they're seeing, and just seeing lots of screenshots from the Health Inequalities Explorer in various slide decks. Or it's been brilliant. And seeing bits in, for example, a fundraising proposal or a business case that's being developed. It's really nice. It's just it's not something that we have to actively encourage people to use. It's kind of taken on a life of its own. And the downside to that is it means it's really hard to know the exact impact it's having, because it's a tool that's out there for people to use, and it's much more we accidentally come across uses of it, which is really nice and really heartwarming. And last year I took it to NHS Confed Expo as well, and we had a demo of it as part of our stand there, and it was just really lovely getting that kind of live feedback from people, seeing how we've been building this app and how we've brought all of these it's all open data sets we've been bringing together, and just really nice getting that live feedback from people, and sort of setting the seed for if you want to use it, you could use it for this, or if you want to collaborate with us on it, here's ways that you could help, that kind of stuff.
That's fantastic. Yeah, and it's those sort of indications, just that feedback, isn't it, that you can just sort of tell the people are using it. Having an impact on outcomes is always, like you say, the reference to accountability. That's always a thing. Sort of coming from a public health background, the impact is 10, 20, 50 years away, but but showing that people are using it in their service planning is the thing that you're after, I guess, and it seems like you're doing that. Well, thank you ever so much, Matt, for sharing that with us. I think it's a fascinating project, and I love the plans for how you're developing it as well. I love that vase as well, by the way. It's a nice vase. Is that a real background?
Yeah, it is. Yeah,
Prove it to me by throwing the vase on the floor.
Yeah.
I'm just kidding. That's just a silly thing to say. That's great. Thanks ever so much. I'm just going to last couple of minutes just say what's coming up next in our lovely huddles. I'm already thinking that you should come back and give us an update in 6 months' time, but we'll talk about this offline. So just moving on, everyone, just to say what we've got coming up next. So our next huddle is going to be about real world data science. So this is forecasting the health needs of a changing population. That's with Luke Shaw. Bristol, actually, he's not on the line today, and I have already said that we might be rescheduling that because it looks like I have a full strategy unit away day on that day, and so unless I can sneak off into a broom cupboard and deliver the huddle, that we might postpone that. I don't want. It's going to be good, so I don't really want to sort of rush through that one. And we have friends from Ordnance Survey who are going to talk about how to produce pretty maps or something very similar to that. We've not decided yet. They've got lots of things they want to share with us, and we haven't firmed up what they're actually going to share. And in November we've got Kevin Dunn from the Health Data Research UK. He's from the Midlands branch of that. So Kevin and I are going to be doing. He's going to be talking about the health data research at that session, but we're going to be doing a joint webinar in early next year. So this is going to be sort of not a huddle. It's going to be in addition to a huddle. We're going to join up and do something really interesting around sort of data and the plus and minus impact of the use of data. That's our thinking at the moment. And just in terms of our training and development opportunities, we've got creativity and problem solving with Fraser Batty. Now that's up and available for us to access. That's on the 6th of November in Birmingham. That's going to be excellent. Strongly recommend you sign up to that. We have Fraser doing introduction to decision quality in December. Also, these are either at the strategy unit offices or the studio. You might have been before if you've been to any of our events. We've got Zoe Turner is going to be doing an introduction to R with dates for that coming soon. And then we've just been talking about R Shiny. So an introduction to R Shiny and dates for that are coming soon as well. So I will stop sharing my screen and I'll be look at the time and I'll be impressed with myself. And impressed with Matt much more than myself. They're running to time. So thanks ever so much, Matt. Again, thanks everybody for coming, and I'll see everybody either in 2 weeks, or 4 weeks. I'll let you know. Okay, bye-bye, everyone.
Thanks so much.
Thank you. Bye-bye.